Okay, everyone, welcome to the latest webinar on perinatal mood disorders. This is the second webinar in our series, and today's topic will cover screening, assessment, referral, and follow-up. We have the agenda for today on the screen here. We'll start by sharing with you some information on the evaluation and contact hours that will be provided for today's webinar, as well as give you an overview of the technology we are using today. I will introduce our presenters, and then we will provide a recap of the first webinar, and followed by rationale for screening, positive mental health, barriers to screening, review of screening tools and the screening process. We'll have a personal story shared, and then we'll have some time for Q&A. Your phone lines have been muted and will be for the majority of the webinar until the question and answer session at the end of the presentation. But there are still ways for you to interact. You can ask questions and provide input to us by typing them into the chat box at the right of your screen. There's also a raise hand function that you can use. If you have a question, we can unmute your line. But if possible, please try to use the chat box because our technology is a little bit more limited. I would also like to mention that there was an email that was sent out to all registered participants this morning with handouts for today's webinar. If you did not receive that email, you can enter your email address in the chat box, and I will send those handouts to you during our presentation. You may have also received an email saying that the session for today and the one in March has been changed. You can disregard that email. Nothing has changed in terms of date and time for these presentations. So as mentioned, we will be asking each participant to complete an evaluation of today's webinar. All registered participants will receive this evaluation within the next few weeks. 2 weeks after receiving the evaluation, you will receive a certificate of 1.5 contact hours that will be automatically emailed to you once you complete your evaluation. If you have questions regarding the evaluations and certificates after this time period, you're welcome to email us at health.fhb@state.mn.us. And with that, I would like to introduce our first presenter, Jean Larson.
Good morning, everyone. London, can you hear me okay?
Yes, I can.
Great. Thank you all for participating today. I really appreciate it. So we're going to start out by just doing a brief recap of webinar number 1. Now, I'm sure some of you maybe have tuned into that one, but just in case you didn't, we started out, in part 1, we started out by introducing really a broad range of perinatal mental health concerns, and then narrowed our focus to really focus on perinatal depression. We talked about risk factors, signs and symptoms to be aware of. We talked about some of the research that's been done, as well as our own experiences, and really noted that the fact that untreated perinatal mental health can have devastating consequences, not only for mothers, both pre- and postnatally, but infants, children, and as well as the relationship. So all of these factors point to the importance of screening, which will be our focus for today. So why, next slide. So why universal screening for depression? First of all, universal screening acknowledges that the fact that all mothers need support and help. We know that approximately half of the clients we see in home visiting will have some level of depression. We talked about that last time. Depression is the most treatable mental health condition, and we recognize the need, and universal screening recognizes the need to focus on mental health and wellness. There's been a great deal of research in the area of screening and home visiting, and one of the findings that was discovered as the most common mistake for sites that are implementing perinatal depression screening was screening only if a woman seems sad. Another point that was emphasized is that you can't tell by looking. And this is similar to other types of screening that we do, for example, domestic violence, developmental screening. So while there's a number of outward signs that we can be on the lookout for, we always need to keep in mind that one's inner experience is not always reflected externally, which points to the importance of universal screening. Next slide. So there's depression screening has gained and hopefully will continue to gain more traction in other settings as a result of both past and recent recommendations. The U.S. Preventive Task Force just released a new recommendation. It was just late in January. Some of you might have gotten emails on that. I got a few. And this recommendation includes screening for pregnant and postpartum women. And it said the recommendation says screening should be implemented with adequate systems in place to ensure accurate diagnosis, effective treatment, and appropriate follow-up. And it received a B recommendation. Next slide, London. So the United States Preventive Services Task Force gives grades of A, B, or C based on the research that indicates the level of benefit. And so for this recommendation, the recommendation for depression screening received a B, and that indicates that there's a high certainty that a net benefit is moderate, or there's moderate certainty that the benefit is moderate to substantial. Next slide. These recommendations were published, as I said, last month in the Journal of the American Medical Association, and this slide that you have in front of you gives you a bit more background and also includes a citation if you want to go back and review that full article. Next slide. So in addition to the task force, several professional organizations have published recommendations as well. On your screen, you can see the American College of Obstetrics and Gynecology, or ACOG. They put out a statement in May 2015, which replaced their 2010 statement. And their current statement says, although definitive evidence of benefit is limited, the American College of Obstetricians and Gynecologists recommends that clinicians screen patients at least once during the perinatal period for depression and anxiety symptoms using a standardized validated tool. And then they also go on to say that if women with current depression or anxiety or a history of perinatal mood disorder or risk factors, they go on to say that they warrant particularly close monitoring. The other organizations that have published recommendations are the American Academy of Family Physicians and the American Academy of Pediatrics. They recommend screening during well-child visits. So before we get into our discussion regarding screening, we're going to take a few minutes to talk about positive mental health, and we're going to start with a polling question.
Great. I just need a minute to pull up the polls. Okay, our first question is, I discuss positive mental health and well-being with my clients and provide tips and tools that they can use to stay mentally well. Your options are yes, always, sometimes, or no, not at all. And you can respond to the poll that's open on the right-hand side of your screen. Okay, it looks like most people have responded, so I'm going to close the poll. And based on your responses, about 55% of you always provide tips and tools with your clients. 26% of you do sometimes, and none of you responded that you never do. So that's great.
Okay, thank you. Thanks, London. So, and thanks for participating in the poll. So at this point in the webinar, it is my pleasure to introduce a wonderful colleague here at MDH, Tessa Weechin. Tessa works as a policy planner for the Maternal and Child Health section here at MDH. Her work involves a variety of projects related to babies and mamas, including efforts to strengthen screening and referrals for postpartum mood disorders. This work includes helping organizations institute universal screening and find good resources in their communities in order to make warm handoffs for mothers with concerning screens. So I'm going to turn it over to you, Tessa.
Good morning. Thank you, Jean. And can everybody hear me okay?
You sound great, Tessa.
Great. Okay, great. So thank you, and I really appreciate Jean and London asking me to be a part of this call. And I sort of, we were kind of not sure where to put this in the presentation because it's not necessarily, it's something that we want to talk about all together and not as a result of screening, but even sort of something we should think about for all moms, not based on how they score on a screen, but just because it's something that's really a good conversation to have with all moms. And the idea is really what can we do to promote positive mental health for mom and for family in general? And then if there are concerns or problems, what else, you know, where the idea, excuse me, the idea here is to sort of talk about it ahead of time, and so that if there does come a time where there are some concerns, we've already identified some tools and some resources that mom might be comfortable using. And so the basic, one of the handouts that Jean sent to all of you is called the Maternal Wellbeing Plan, and this is a modified version of what's called the Depression Action Plan, and it's used nationally for a long time to sort of, to generally promote positive mental health and specifically to support people with depression on taking some actions to improve their mental health. But so the Depression Action Plan itself really focuses on sleep, nutrition, exercise, and connection. And so what we did is modified it slightly with the help of our women's health consultant and with the help of a number of medical providers, and also working with lactation specialists to understand what are the best, you know, what advice can we give moms about getting good sleep and rest while they have a newborn, which is certainly not the same as for other people, right? And so if you look at the Wellbeing Action Plan, it tries to just kind of give some very basic language around what does it mean to be healthy and what are the key things you can do around support, rest, good nutrition, and connection with other people. But then it also, on the back side of it, it has a very specific, fairly specific questions that you can go through with moms. And this, again, is designed to be used either ahead of time as a prevention tool, as just sort of a conversation that you have before there's any sort of concerns around positive mental health, or after, or it certainly also can be used when concerns are identified. And so some of those questions include things like, as we plan ahead, where are places that you can relax? How do you relax in your home? What are some easy, nutritious foods that you can have available? And then key is this concept around who are people I can ask for help. And what we're encouraging you to do is really talk moms through that and not say, you know, if mom says, oh, I'll ask my friends. Well, we're going to need to be more specific than that. You know, like who is a particular friend or a family member or a coworker, someone you really think you can rely on, who you would ask. And then this does have a place where it has some phone numbers moms can call for help within Minnesota or for contacts. The two key support lines in Minnesota are both what's called a warm line, which means that moms won't receive, are not likely to receive an immediate response, but they'll receive a response within 48 hours. There's also a crisis hotline phone number. But this also is a place that they can kind of say, you know, I'm not there right now, I feel good right now, but in my mind, these are the things that would show me that I'm not doing well. So for me, for example, I have a 3.5-year-old and a 2-year-old, and one thing I know about myself is that when I start to feel off in mood, I don't sleep, you know, so I can't get to sleep even in those moments that I have sleep. And so for me, personally, I thought, okay, well, this is a sign if I'm not sleeping, that's a sign that I'm not sort of mentally as healthy as I could be, knowing that I need sleep and that it's a good time to be sleeping. And so one thing moms can do is sort of talk through what's something, you know, do we eat way more than we should? Do we eat way less than we should? Do we snap at people? Sort of what are the signs that something isn't feeling right emotionally, and sort of identifying those ahead of time if possible, and then saying, okay, if this is happening, who is someone I would talk to specifically? You know, I will talk to my doctor, or I will talk to my friend. And then what are you going to say? Are you going to say, I need help? Are you going to say, I can't sleep and I don't know what to do? Or what are you sort of helping? And this is a lot to say, I think, to kind of work through this with someone, but the more we can use these kind of ideas to help mom create a plan for if it's not going well, it's a preventative measure. And then if you know, just looking back at the first page of this, we have sleep, eat well, move, and connect, and talking to mom about how all of those things can help you stay healthy, help everyone stay in a good mood, not just mom. And we're not talking about we all have to be, I want to caution that when we talk about staying in a good mood, we're not talking about like everything has to be roses all the time. It's not a false sense of everything's great, but it's more a functional, healthy mood for raising a family and for dealing with a new baby on lack of sleep and all of those issues. So we're excited about this tool because we did create it with a bunch of people who have sort of knowledge about how to help moms. And I think what I encourage people to do is take it and look at how would I use this in a conversation with a mom. When mom is doing well, can we talk about great, you're doing, you know, you're clearly doing these healthy habits, and how are you, you know, what helps you keep those up? If mom is starting to feel a little rough around the edges, how can these things be incorporated? And also, what we had our providers do, so we were screening, the project that we worked around that helped us develop this, screened for postpartum depression in the Well Child checks. And so plenty of moms did not screen positive, you know, did not screen at a concerning level for postpartum depression, but they were sort of getting there, or they weren't, you know, it wasn't perfect, or it wasn't, perfect isn't the right word, it wasn't a 0 score. And so this was another tool that the provider could bring out then to say, you know, you seem to be doing fine, but these are some things to sort of think about as you move ahead with maintaining that positive mental health. So yeah, so that's the tool and how I think it could be used, but also just the general overall concept of mood and mental health is a key piece of all of our lives and our function and the way that we live in this world. And so thinking about how to get the rest, the nutrition, the exercise, and the connection with others that helps us maintain that is a really great conversation to have.
Tessa, we have 2 quick questions.
Great.
The first is the maternal well-being plan available in other languages?
It is, actually. We were very fortunate to have the funding to have. So the maternal well-being plan, there's a link that we can provide you. It is also on the same page on our website that has the postpartum depression fact sheet, and it just has sort of general facts about what postpartum depression and anxiety are. So both of those tools, or both of those documents are available in actually 7 languages. So we have English, Amharic, Hmong, Karen, Somali, Russian, Spanish. That's the 7.
Okay. And then the other question is, are there issues with insurance billing if providers need to intervene after a depression screening for the mother at a well-child check?
It's actually, Minnesota has a very, it's a very much approved activity. There is a code, there's a billing code that means you're billing for maternal depression within a well-child check. The charge goes on the child's insurance. It is actually a recommended practice for child and teen checkups. It's not required yet, but recommended, and it is not, there's no billing or insurance concerns. It is supposed to be billed to the child. It's thought of as a child well-being or at-risk screen, so similar to like asking if there's smoking in the house or if there's, you talked earlier about a potential domestic violence in the house. It's considered in that category, and it is billable onto the child's insurance during a pediatric visit.
Thank you.
Okay, ready to move on? Tessa, thank you so much for speaking today. I really, it's nice to hear the emphasis on primary prevention, and the strategies are really important. I think we're going to need to come back and visit some of those next time as well. So before we get into the nuts and bolts of screening, I have a slide that talks about some barriers. There's been a lot of research in the area of screening, and some of this research has revealed some barriers, and those are the ones that you see on this slide. So just making note that talking about depression can be uncomfortable. It can be challenging to bring up, and I think, Tessa, what you've offered really helps with that, so thank you. Some people have identified a lack of training on how to screen and how to handle positive screens as being a barrier, knowledge deficits in mental health treatment, not knowing what to do if they have a positive screen, lack of resources to refer women to, and we know in a state the size of Minnesota that there certainly are issues in that area. Having a lack of regular supervision, someone to check in with. And then finally, literacy and language barriers have also been identified. So I've mentioned the toolkit. I mentioned it on the first webinar, and I'll bring it up a couple of times today. Just in recognition of some of these barriers, the SAMHSA toolkit does provide some guidance on how to have a conversation with a mother. So, the next slide, London. So the next slide is titled Tips and Tools for Working with Mothers Who May Be Depressed. This comes from the toolkit. The authors of that kit highlight 3 different tips, and we're going to focus really on number 1 and number 3 today. So number 2 we'll focus on in the next webinar. But for that first tip, let's take a look at that. And the first tip is to ask a mother how she's feeling. And the toolkit offers several examples on how to bring up that question. And essentially these questions are meant to open the door for this conversation and can serve as a segue then to using a standardized tool. So asking questions, how are you feeling? Have you been feeling down? If so, for how long? Can you tell me more about how you're feeling? And while you're asking these questions, listening closely for feelings that suggest despair, loneliness, and guilt. And we know that those are all can be present with a diagnosis of depression. It's important to note that our ability to recognize and describe what we're feeling is really related to a concept known as mental health literacy, and I'm going to talk about that a little bit more in a minute. Keep in mind that a mother may not make the connection with how she's feeling in depression, so that's where I think, again, back to some of the comments that you made, Tessa, having that conversation early on about what is mental health, what does it mean to be mentally well, can really help with that. So next slide. One more. Thank you. So many of you are familiar with the term health literacy, and that's defined by the Institute of Medicine as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services that are needed to make appropriate health decisions. Next slide. So a close companion then is mental health literacy, and that's described as knowledge and beliefs about mental disorders which aid their recognition, management, and prevention. So in other words, being able to recognize signs and symptoms and knowing what will help. This also, this pertains to maintaining a positive mental health, as well as knowing when things are just not right. And Tessa mentioned that in her comments. When I know when I start feeling this way that, I need to be doing something different. So the folks who did this study that looked at mental health literacy, they did a series of focus groups with postpartum women who were lower income women. And they found that women were able to recognize changes in their own mental state, either through their own self-appraisal, they could recognize it in themselves, or through by other people saying, boy, something's not right. And so when they were asked to describe what they were feeling, some women used the term depressed, and other women described themselves in other ways. So for example, they might say, I'm stressed, I'm just not myself. I'm a negative person. I'm feeling really snappy and irritable. Something's not right. This is not me. And so, and some women just really could not label their experience at all, but until a family member pointed it out to them. So I bring up these points just to make the point that talking about feelings with women can be really helpful. And I'm thinking back last time we talked about the women warrior stories on postpartum progress, and I think one of the things that I really gleaned from that is that it helps us understand that really the heterogeneity of depression, it can look and feel very different for different people. Next slide. So with all that being said, admitting depression isn't easy, and go on to the next slide, London. And we know that because of the experiences of clients. Again, the authors of the SAMHSA toolkit, as well as the study I mentioned previously, they cite a number of issues that have been shared by women. For example, admitting depression may raise the mother's concerns that she'll be seen as a bad mother or that her children will be taken away. A mother may worry about being perceived as crazy. If a mother had a negative experience seeking mental health care in the past, she may feel really frustrated and discouraged and not want to seek treatment. So I'm taking a minute to emphasize these points because we know that these fears are real and they're based on personal accounts from women. So I'm guessing that some of you may have also heard some experiences from your clients, and I just wanted to take a minute to really validate those experiences. So it's important for us to really appreciate how this can impact disclosure. So when we ask questions about depression, when we use a standardized tool, having these factors in the back of our mind, knowing that they can impact whether or not a person is going to be able to answer the questions. Next slide. So there are some things that we can do, and Rebecca, who's with me today, is going to talk about, emphasize some of these points as well, but providing a safe and accepting place to talk about feelings, being a good listener, and really offering support for her feelings. Those are things that we can do, things that we've learned from others, including home visitors, to keep in mind when you're screening. Next slide. I added this slide in addition to the toolkit. These are some other resources that share, that provide additional guidance on screening, which might be helpful for your program. So I just wanted to make you aware of those. Next slide. I'll turn it over to you, London, to introduce the poll.
Great. So for our second poll, we are wondering, for those of you who are screening for depression, which tool are you using? Okay, so I'm closing the poll. And it looks like about 1% of you are using the PHQ-2, 47% of you are using the PHQ-9, 19% of you are using the Edinburgh, 5% are using another type of screening, and 1% of you are not screening. We have one more poll for you, and that is, for those of you who are screening, are you following an established protocol that indicates specific screening intervals? Yes, no, or you're not sure. Okay, you have about 15 more seconds before this poll closes. All right, and from the responses we received from this poll, 57% of you are using an established protocol, 8% of you are not, and 4% of you are not sure.
Okay, thanks, Lena. That's helpful. So I have a slide titled Perinatal Depression Screening, the Algorithms. Some of you might be familiar with these algorithms, which are really basically like a clinical guide that were developed and sent out in June of 2014. They went out to all local public health agencies, and I'm wondering, Lennon, if we had them in Tuesday topics, but that's our communication, one of our communication tools in family home visiting, but they were purposely created in an editable format so that programs could revise the algorithm to fit their specific program. So what we're going to be coming back to we'll come back to the algorithms in a bit. So if you would keep them handy, if you've made copies, that would be great. So because we'll be talking about them a little bit later in the webinar. Next slide. So as I mentioned earlier, it's the most common mistake when we're implementing perinatal depression screening is to screen only if a woman feels sad. So we promote the idea of universal screening. It's best to screen routinely and based on a protocol for your agency regardless of the client's apparent health. And unlike some screenings that are in place for other conditions, the research to date has not identified a particular time of vulnerability that guides our screening. So in other words, there isn't an evidence-based screening schedule for perinatal depression. So you're going to see different protocols in place. That being said, it is recommended that women be screened once, at least a minimum of once during the pregnancy, in the early postpartum months, with additional screens throughout that first postpartum year. I would say typically what I see is screening about 5 to 7 times during the course, depending on how long you keep a client open. Some home visiting models suggest screening up until the second birthday. And then I did come across one study that recommended screening more than once during the pregnancy, and this recommendation came out of the idea that there's more accuracy in diagnosing depression and anxiety if you screen more than once during the perinatal or during the pregnancy. So next slide. So based on the results of the poll, it looks like the PHQ-9 is the one most frequently used, but we also have people who are using the EPDS as well as the PHQ-2. So I'm going to talk about each one of those tools. The PHQ-2 is used in home visiting, and it's also used in some primary care clinics. It can be used as a standalone tool, or sometimes it's used in conjunction with the PHQ-9. So it asks 2 questions, and the questions are the first 2 questions of the PHQ-9, and you can read those questions, and you can see that there's a response option of 0 to 3. Next slide. The PHQ-2 score then can range from 0 to 6 with a score of 3 indicating a possible depression. So on that slide it tells you what it gives you what we'd call the psychometric properties or the sensitivity and specificity. I will want to point out that all the tools that we're going to be talking about today have really good psychometric properties, so they're all good choices regardless of the one that you're using. And next slide. With the PHQ-2, it's also used with a yes or no response option, and so for sites that use the same, they may start with the PHQ-2, and then if a person answers yes to either of the questions, that would trigger them to go on to complete the PHQ-9. So that's typically how I've seen it used in practice. Next slide. So the next tool that we're going to talk about is the PHQ-9, and you can advance a couple more. And I'm not sure if everybody had a chance to print out the materials that went out prior to the webinar, but you have a copy of the PHQ-9 as one of the attachments. The PHQ-9 has been used with a range of cultures. It's been translated into many languages. If you go to page 7 and 8, for those of you who have printed the SAMHSA toolkit, if you go to page 7 and 8, you'll see that there's a very nice description of the PHQ-9, and it offers some selected cutoff scores and suggested interventions. Now, we're not going to be talking a lot about interventions during this webinar. We're going to save that for next time, but the SAMHSA toolkit offers 3 cutoff scores, so 0 to 9, they consider not depressed, 10 to 14, some depressive symptoms and needs more support, and then they use a cutoff of more than 14 as being likely to be depressed, and then where a referral would be necessary. Next slide. So for those of you who are using the PHQ-9, I'm thinking you probably have had access to the manual, but the PHQ manual actually really provides multiple cutoffs. So as you can see on this slide, you've got 1 to 4, 5 to 9, 10 to 14, 15 to 19, and 20 to 27. So that really breaks it down quite a bit further. So before we, next slide. So before we go on to the next, go on to the next tool, I'd like you to pull up the algorithm if you have that algorithm for the PHQ-9, and I'd like to just go through the algorithm briefly. It's pretty self-explanatory. Again, I want to emphasize that it was designed as a template or a guide so that you can modify it. You might choose a different cutoff score, for example. But similar to the toolkit, for a score of 15 or greater, you would provide a referral, or if a person scores positive on question number 9 that really refers to suicide and self-harm. Again, your agency might choose a lower cutoff score. For example, you could decide to refer a person who scored in that 10 to 14 range. Or, and I've seen this too, you might think about developing a range of resources or interventions that you could use for the various cutoffs. So if someone scored between 5 and 9, you might say, okay, this is what we're gonna do this when a woman scores between 5 and 9. Back to the algorithm though, it's recommended that that for a score of 15 or greater, you make a referral. Now, if the score is less, there's a box there that says, does clinical judgment warrant further assessment? And in this situation, I'd like you to think about some of the risk factors that we talked about last time. So, for example, is your client in a domestic violence situation? Do they have a limited support system? Do they have a previous history of depression, or do they have a family history of mental illness? Are they living in poverty? Those are all sorts of things that would really factor into that assessment and cause you to think a little bit about how you want to proceed. They might score lower than 15 and have a lot of those other things in place, and you think, you know, I'm going to refer them. So again, this is a guide. It never takes the place of your judgment, your clinical judgment, so keep that in mind. So as you go through it, you can see, is there imminent danger? If yes, you're going to refer to the crisis intervention algorithm, and we'll talk about that a little bit later. And then there's a box if no immediate referral is needed, and so it just gives you some ideas of what you might do. And then that lower box expands on that even more, and we're going to talk about that a little bit later. So let's move on to the next screening tool. And this is the Edinburgh Postnatal Depression Scale, which I think it was about 20% of you maybe were using this tool. You can go ahead and advance the slides, London. One more. So this tool has 10 questions that can easily be completed in less than 5 minutes. Again, the responses are similar to the PHQ-9. They're scored 0 to 3. It's important to note that there's a couple items that have an asterisk, and those are reverse scores, so you're going to score them in the opposite way. And then the total score is determined by adding the scores for each of the 10 items. The EPDS was developed for screening postpartum women in outpatient and in home visiting. However, it's very much used during pregnancy. And like the PHQ-9, it's been used with numerous populations. And let's take a quick look at the algorithm for the EPDS. Can you advance the next slide? So again, very similar to the algorithm for the PHQ-9. In this case, if the score is 10 or greater, that's going to trigger you to do something. We talked about clinical judgment, based on your other assessment. And so other than the score, really, the algorithm is the same. So we won't spend a lot of time with that. Next slide. And the last algorithm that was created back in 2014 is the crisis intervention algorithm. And this is when it's determined that a mother is either suicidal or homicidal, this is where you want to use this crisis algorithm. And I would really encourage you to be thinking about this ahead of time. It's not, hopefully you're not going to see this come up in your practice, but it's really, really important to have a plan in place in case it does. And again, this is an editable algorithm which you can edit to meet the needs of your agency or your program. Again, so I'll just, maybe briefly cover this. It tells you, call emergency resources, staying with the client, collaborating with the mother for care of her children. So again, thinking about considering friends. And I'm thinking back, Tessa, to your comments about knowing who you would contact. It's really helpful, I think, if we talk to our clients about, who are you going to call in an emergency? It's really important for them to know in their own minds who could help them out in time of need. So again, the algorithm has you assist with arrangements as needed, of course documenting what you've done, and contacting the care provider. And then the follow-up is really talking about it with your supervisor, contacting the client the next day to see how things are, and really staying in touch. So that's pretty much the crisis algorithm. So next slide. So I'm just going to briefly touch on the tools. It sounds, you know, the main tools that I heard being used are the PHQ-9 and the EPDS. I think it's important to note that all tools have strengths and limitations, and they're, one thing nice about the PHQ-9 and the EPDS, they're both available at no charge, and they're really easily accessible. So, and actually all of the PHQ tools, if you look at the manual, that they have, there's a PHQ-2, the GAD-7, which looks at generalized anxiety. They're all available easily online. So with the PHQ-9, the value of the PHQ-9 is that it matches the DSM-5 criteria, and that's the diagnostic criteria that's used clinically to determine if someone is experiencing depression. It's used across all ages, so there's some benefit to that. It's maybe more acceptable to use in clients who have older children. It's not geared as much to the postpartum period. The downside, and I know from talking to folks that this is true, that some questions mimic the normal experience of the postpartum period. So you have to sort some of that out when you're, it might cause you to ask a few more questions if you're using the PHQ-9 in the postpartum period. With the EPDS, the scores can change based on ethnic groups. Typically, there's a range of cutoffs that what I've seen in the literature is 9 to 13, but it really varies depending on specific ethnic groups. There is one cutoff score, which we've talked about. And so the other consideration is, and I've had this has come up in groups that I've met with, is thinking about what other people are using in your community. So if you have a lot of providers in primary care or in pediatrics that are using the PHQ-9 or they're using the EPDS, using a similar tool gives you a common language. So that might be some advantage and something to think about as well. So London, do we have any questions?
Not at the moment.
Okay. Well, at this time, I'm going to turn the presentation over to Rebecca Paulson. Rebecca is a public health nurse with St. Louis County, and she has experience both in the NFP program, working as a nurse in the NFP program, as well as generalized home visiting and in the WIC program. In fact, she's been co-leading a depression screening pilot in WIC. So in addition to these roles, she's currently serving as the interim NFP supervisor for St. Louis County, and I'm just delighted to turn this presentation over to her and thankful that she could be here.
Well, thank you so much, Jean. I am so passionate about working with moms, and I feel so fortunate to be engaged in this type of work particularly. So thank you so much for asking me to be here. So taking a look here, we know that Jean mentioned that conversations with clients about sensitive topics such as perinatal depression can sometimes be difficult, and that these screening tools can be an aid in the discussion and can kind of provide a window into how the client is currently feeling and better understanding of which clients we want to refer on for mental health services. So I'm going to talk a little bit about how to introduce a screening tool to a client. I think about 57% of you mentioned that you have protocols that you're following on when you are going to actually routinely screen someone for depression. Something to keep in mind is that many women are going to wonder why they're asked to complete a depression screen, because pregnancy and postpartum are really supposed to be this joyous occasion that everyone talks about and celebrates. Some clients may feel that they are going to be bad moms if they're depressed, and it's important for apprehensive clients to understand what perinatal depression is and to know that many other moms experience similar feelings. So those are some things to keep in mind as well. So when we talk about protocol or not protocol, when we're looking at timing, I'm not necessarily talking about when in terms of number of weeks or months that you're going to be administering it, but really in terms of timing when you're engaged with the mom. So if you're in a home visit it's important to think about that you may be the one person that this mom has an opportunity to connect with throughout her day. You may be the one person that she's going to share information with. And so when you walk in the door, if you may know based on your protocol, or you may not know if you're going to administer a screen, but taking the time to think about when is the appropriate time in a visit or in a clinic to go over and to talk with this mom about this sensitive material and creating a safe place for her to be able to do that. So for example, maybe thinking about building some rapport in the relationship. Maybe it's the first time you are seeing the mom and you think you're going to offer and administer a screen. Thinking about maybe having some pleasantries first, getting to know her a little bit before you are taking out the tool and saying, okay, let's walk through this, but really getting a sense of who she is. Is it chaotic at the moment? I mean, what's going on around in the home, maybe in the clinic, what's happening? So really thinking about the right time to administer the screen. Privacy is going to be important. We really want the mom to fill out the screen herself without input and aid from others. That's really important. So if you're in the home, maybe you offer, if the mom is comfortable, to sit with the child for a moment while she takes a moment to think to herself if she feels like she'd be better suited to go into a quiet space. And not only privacy in administering the screen and filling it out, but also privacy when you are going to talk to the mom about it. A lot of times in home visits, the mom is there with other individuals, and she may not feel comfortable right at that moment talking in front of someone else. So kind of trying to gauge that based on maybe mom's actions, body language, or also asking, are you comfortable talking about this right now? Eye contact. It's not just eye contact. I know I have that listed on the slide, but I guess maybe I could have inserted presence and being present in there as well. So instead of just handing over the paperwork and having the mom just fill this out as if she's filling out just her name and address information, really engaging with the mom, taking the time to look her in the eye, to talk about, to offer some of your own sincere body language, tone of voice, and be engaged with her to talk about what it is that you're going to be having her fill out. Letting her know that this is a universal screen. So when I say that, meaning we're not just singling out this mom. This isn't because of how we're perceiving her to act or not to act, but this is something that we talk about with all mamas, that it's just something that we feel is really important, and we want to check in with her and see how she's feeling, but we do this with all of our moms. And then letting her know that when she fills this out, that there's support if needed. So talking with her and saying, you know, based on what you fill this out, and either way, I just want you to know that I have supportive resources available if you're interested. So sometimes letting moms know that ahead of time can be comforting to them so that they know that, okay, I'm not just filling this out and it's falling to deaf ears and we're not going to do anything about it. I know in our communities, not all of our physicians are screening, so like I said, this might be the one, you might be the one person who is asking these questions. And so I think the goal is really to try to create a safe, comfortable space for a mom to be honest about what's happening. So we'll go on to the next slide. One of the things that I put here, and these are just some sample scripts that we're going to cover, and there's just two, one for the prenatal, one for postpartum, that we'll just read through these briefly. But it's important to note, too, that these are just examples, and, you know, once you've been screening for a while, you're going to find your own wording that fits for you, or maybe it changes and it's not some canned approach. This is not meant to be any sort of canned approach, but just as a way to, as a guide to kind of help you when you're introducing the screen. So for the prenatal period, and the two are very similar, but it states, one of the things that I do with all of the pregnant women I visit with is to check in with them periodically regarding how they're feeling. I'd like to check in with you regarding how you've been feeling over the past maybe 2 weeks. It really, this kind of depends on how the screen that you're using. And if you could please take a few minutes to fill this out and we can chat about it. So that's an example of something we could consider using in the prenatal visit. Postpartally, I'd like to check in with all the moms that I visit with after they've had their baby in order to see how they're feeling and coping with all the changes that a new baby brings. If you could please take a few minutes to fill this out regarding how you've been feeling over the last 10 days, we can chat about it. So again, just some examples of ways that you could potentially consider starting off with a client. So thank you.
Great, thank you so much, Rebecca. We're going to come back to Rebecca in a little bit, but before that, I'd like to spend a little bit of time talking about positive screens and how ways that we can go about handling that. There was a handout in the materials that went out this morning. It's titled, What is Next? Positive Screen for Depression. I'm not going to read through this entire document, so don't worry. But I want to just highlight a few things. So if you have a positive screen, say you're using the cutoff score of 15 for the PHQ-9 or a score of 10 for the EPDS, if you, which are both considered positive results, this woman obviously this woman is suffering from many of the symptoms of depression. It does not mean that she has depression. These are screening tools. They're not meant to be diagnostic, but you're clearly seeing some symptoms. And so it's important to recognize that. So how do I know in this form I'm looking at, how do I know if I should make a referral to a mental health professional? So we talked about the cutoff scores, 13 or more on the EPDS, 15 or more on the PHQ-9. Now, you might have lower scores, and again, we talked about that further assessment, really determine that, this does require a referral. You're going to use your judgment on that. So if you've determined that if they have a score like that, one of the things you do want to ask is if they have any thoughts of harming themselves. So, any person who's so do you have any thoughts of harming yourself? And for sure, if they answer positive to that, they need to talk to somebody. That warrants a referral. And then the other question is, do you have a plan to hurt yourself? So have you had thoughts, and do you have a plan? Those are two really critical questions to ask when you see an elevated score. So one thing to note too is that the tools are meant to over-identify, so you keep that in mind. It's possible that a person will score less and still end up having a diagnosis of depression, but they're screening tools, and we need to be thinking about them as that. So if you have a client, there's a section, what else can I do? It's really important to listen and validate what the person is feeling, and Rebecca emphasized that in her comments. Let her know that it's not her fault, she's not alone. I'm sure you could speak to your own experience in screening that that about 1 in 5 people are going to experience depression after childbirth. So while it doesn't happen in everyone, it certainly happens fairly often. And also letting the mom know that there's treatment available and that it's very effective. We know that depression is one of the most treatable conditions, and really giving a mom that sense of hope that there's help is I can't even emphasize it enough. We want to instill that thought of hope that, yep, I can get some help for this. So here I'm going to share a couple of scripts. So here's the first one. I really appreciate that you've shared what you're feeling with me. Based on what you've told me and your score, I'm concerned that you have some symptoms of depression. What you are feeling is real, and it's not your fault. It can be hard to feel this way when you have a baby and young child. There are things you can do to feel better. Let's talk about some ideas that might work for you. So that's just a sample of, just a sample script that you can use. And I have another one I'll share in a little bit, but if you turn the page over, again, just emphasizing that your support and validation is extremely powerful and can really make the difference as to whether or not this person is going to seek help. When we meet next time, we'll talk about care, and we know that for some women there will be resistance, and it goes back to some of the barriers that we talked about earlier. So really that encounter that you have with a woman with a positive screen is really important. Providing education about depression, leaving information. Tessa gave us some nice examples, and there are others. Encouraging an appointment with her primary care provider, and depending on if a woman's postpartum, some women are going to feel really most connected with their OB provider, and they'll want to go back to the OB provider. Some people might be really connected with a pediatrician or with their baby's doctor and want to go that route. So, finding out where the woman wants to seek additional support. Informing her of mental health professionals in the area, providing contact information. If you haven't created a list of providers in your community, I really encourage you. I know for some of you, that'll be a really short list. I was in a community where they basically had 2 providers, and that's hard. That's hard when you have a really limited resource availability. But to the best that you can, start making a list, and then really talk about support, helping a woman gather support. And again, I'm going to go back to what Tessa said, is thinking about that early on, thinking about when a person is mentally well, thinking about, okay, who can I reach out to? Having that in the back of your mind, so rather than waiting for a crisis to happen, knowing in the back of your mind. So I think I'm going to leave the rest of that page up to you. And again, we're going to be talking much more extensively the next time about interventions that you can use. Can you go to the next slide? And this is just another script that you can use. I really appreciate your filling out the screen. Again, acknowledging that they've done it, knowing that it can be hard. It looks like you're having a difficult time. I want you to know that our visits are a safe place to talk about how you're feeling. Would you be willing to share a bit more? I have some resources, and if you're willing, we can talk about some things that you can do to feel better. If you're interested in other resources, we can talk about that too. So those are just some ideas. I'm sure that you have your own scripts, especially those of you who are seasoned visitors and have a long history of screening. You have your own script. So feel free to share those with others. We'd love to have more ideas. So we're going to move on, or I'm going to move on to back to Rebecca and sharing a personal story which really emphasizes some of what we've talked about today. And so I'm going to pass it back to you, Rebecca.
All right, thanks again, Jean. So I can't even begin to describe how excited I was to be a mom. I had anxiously waited for years for the moment that I could feel a baby moving inside of me, and remember talking to my friends and family about what that moment would be like when I could actually make eye contact with my own child. I vividly remember seeing the telephone number on my phone from my nurse practitioner the morning I found out. I excused myself from a meeting that I was in and took the call. When I answered, she said, "Rebecca, are you sitting down, girl? Because you're pregnant." My head started spinning, and I felt like I was in a dream. I thought I was going to pass out. I could not believe my good fortune, and the dreams and visions danced in my mind from that day forward, thinking about what our lives would be like after our baby was born. I felt fortunate because I had worked as a home visiting nurse in our maternal child division and had endless resources at my disposal. I had an uneventful and healthy pregnancy. I had a tremendous support system, and I was looking forward to significantly more time off with my baby than most people I knew. So basically, I looked really good on paper. However, as the saying goes, no one can prepare you for being a parent, or postpartum in my case. I ended up having a long and traumatic birth, a baby boy who cried for hours and hours every day, and great difficulties with breastfeeding. I was trying to sustain on hours or what felt like minutes of sleep every day. I remember thinking that this is not what I signed up for. How do women honestly enjoy this? My feelings went on for days and turned into weeks. I became reclusive. I did not want anyone stopping by, and my mind was racing, my body was sweating, and I'd never felt like this in my entire life. I remember finally talking with my husband and sharing some of what I was feeling. He, of course, already knew that I was not acting like myself, but he was also in the midst of transitioning into life with a baby who never seemed to stop crying, so it was difficult for him to clearly see all that was happening with me. He encouraged me to talk with a close mentor of mine who ran a postpartum depression support group. I vividly recall saying to him, "She cannot know that I'm dealing with this." I felt embarrassed and ashamed. I felt alone. I continued to think that things would get better on their own. Even though I worked with women in the perinatal period and routinely screened for depression and referred as necessary, somehow I thought it would be different for me. Clearly, I was not in my right mindset. I finally decided that when I went in for my postpartum checkup, I would consider talking about it because I felt so unlike myself. However, when I went in for my appointment, that is not exactly what happened. I was nervous, and the initial nurse felt so cold to me. She was hurried, made a few comments about how everyone goes through things, never once made eye contact with me when she administered the depression screen. I got the sense that she did not really want to know how I was doing. Basically, "You're okay, right?" I did not feel comfortable, and I knew how to answer the questions to elicit a negative screen. So I lied. I basically hit what felt like rock bottom to me 2 weeks later, and I could no longer go on feeling the way I was. I needed help, and I knew it. I finally called a trusted colleague and disclosed to her how I was really feeling. She met me where I was at and essentially held my hand and walked me through one of the most difficult times of my life. I called my doctor, I called a therapist, I called upon my support system. I answered truthfully when I was screened at my son's 2-month appointment. It was his pediatric appointment, and I did that because they listened. They genuinely seemed like they wanted to know how the mom was doing. It took some time, but with help I got better. I won't go into all those details, but I'm better now and truly appreciate the sheer joy that I have found in that comes from only being a mom. I'd never again want to go through what I felt before, but I want to use it to shape how I and how we care for moms. Screening is certainly not the catch-all, but done sensitively and being present, engaged, and open to hearing what the mom has to say is a step in the right direction to not only helping the mom, but her entire family. So I share that as a way just to say on paper, you might look really good and that everything looks like you have your support systems in place and you didn't have a history of depression or anxiety, you're a nurse or you're, work in the medical profession, but it can really happen to anyone, and having a safe and comfortable place to talk about it is definitely the best thing for the mom. So thank you.
Thank you, Rebecca. I'm almost speechless. I really appreciate your willingness to share that. I think when we talked about putting this webinar together, the point that I really wanted to get across most significantly is that sensitivity and recognizing how we are with women, how we present a screening is so critical. And so anyway, you illustrated it beautifully, so thank you. London, I am going to turn it back to you. Are there questions or comments?
There is one question that came through on the chat, and at this time I will unmute all callers' lines. So please be aware of any background noise that might be occurring where you are. If you do not wish to be unmuted, once you hear that all lines have been unmuted, you can dial *6 on your phone and your line will be muted again. So I will unmute us now.
I have a question.
Okay. Okay. Go ahead.
The reason I'm prompted to ask is I was just in some training yesterday, unrelated to this, but regarding hearing and vision screening for CNTC. And the guidelines there are if you already know somebody has a diagnosis, you don't screen. So I'm wondering, in the case of depression, if you already know a client is diagnosed with depression, do you then still go ahead and do the screening, or do you not? Do we have protocol or recommendations for that?
I can speak to that if you want.
Please.
This is Tessa. And others feel free to add in, but when we've been doing it in the pediatric office, absolutely we're screening anyway, because even if a mom has a diagnosis, she should be receiving treatment and being supported. And so a mom who has a depression diagnosis could actually be doing well, and if a mom is not doing well, if she's screening really high on the tool, then we need to make sure she is actively receiving the treatment and support she needs. And so it is perfectly, or not perfectly, but it is common that you can screen mom and mom can say, oh yes, I've had a problem with this, but then the conversation is, well, how recently have you seen your doctor about this, or are you currently in therapy? Have you told your therapist that it's not going well, or your doctor or your provider? So even though even if there's an awareness that there is a past diagnosis there, the screening tool is still a helpful way to kind of check on how is it going for you right now.
Perfect. Thanks for clarifying.
And Tessa,
but I appreciate the clarification.
Yeah, this is Jean. I would concur with Tessa, and in practice, the screening tools are really used as a measure of how the treatment is going, and so it's really, I would encourage you to screen. Thank you.
Thank you.
Good question.
Okay. Jean, we have a question for you that came through on the chat regarding the handout on what's next for the positive screen for depression. That handout recommends a referral for a score of 13 or greater on the EPDS, and the algorithm recommends a referral score of 10 or greater. So can you please clarify which score is appropriate for referral?
Oh, God, yeah. Oh, yuck. Tonight.
Jean, did you hear the question?
Sorry, London, I muted myself. I need to go back and just double check. That's not a tool that I have used, and I'm sorry for the discrepancy.
I'm sorry, London, can you say again which tool it is, because I can look it up too.
The EPDS.
So the handout we provided today is the one that's titled What's Next? Positive Screen for Depression. Recommends a referral for a score of 13 or greater. And the algorithm for, on the EPDS, and the algorithm for the same scale recommends a referral score of 10 or greater. And so our participant is wondering which scoring we should go by.
So I would say 10 or greater is what I've seen, but Jean, I'm happy to defer to you. The EPDS online thing says possibility of depression starts at 10 or higher.
Yeah, and that's so it kind of goes back to the issue that number can move around a little bit depending on the
Hamilton. And she told me was scheduled for lab work today, but I didn't get any.
Just a reminder, everyone, that your phone lines are unmuted, so we can hear you and your background chatter. So please be sure to dial *6 on your phone if you wish to mute your line.
I know the feeling. Yeah, that's all.
Yeah, I think that's all I'm going to say about the EPDS, but I will make sure that they're consistent. I concur with Tessa being 10 or greater. The range is typically 9 to 13 is considered a positive screen.
Okay. And now we have another question. What do you recommend as far as referring when the score indicates a referral is required, but the client refuses or does not want the referral?
So I would recommend that you this is an opportunity for a longer conversation with the client about who are they willing to talk to. Because I think the word referral can indicate to them, like, I mean, I don't assume you're using the word referral necessarily in that context, but I think the conversation is around, look, this isn't how it has to be, and life can be different for you and your family right now, and we really need to figure out how we can move forward on that. And if that means, you know, who are you willing to talk to? Are you willing to talk to a past doctor? Are you willing to talk to a past therapist? If I find a support group in your area, would you be willing to do this? Would you do a phone call? Sort of, I would say, going through a number of different options for at least starting that support and asking about those. And I would think this is the point, too, where it depends on, is mom in crisis/suicidal mode, in which case you really do need to contact a crisis team. If mom isn't, but is not just plain not doing well, then I guess I would leave it up to Jean. What I would recommend at that point, saying, this is why I'm so concerned, can I call you and have another conversation with you later or something? Jean, what would you say?
I'm going to refer people. I'll say a few things, and then I'll also refer people back to the SAMHSA toolkit. If you look on page 9, it's true that not every person that.
You have to come today.
We're having a little trouble with. Maybe you could mute for a minute.
She has lab work ordered though, and I'm not.
Okay.
Lab orders.
I'll mute that caller.
Okay, so it can be it can be really challenging. So, and again, thinking back, you know, they may have had a negative experience with treatment in the past. I think really going over, having in the back of your mind who would be a good referral source, letting them know that there are multiple options. Letting them know that they may not like the first treatment. They may try medication. They may not feel good with medication. They may have gone to a therapist that may not have been a good fit. So I think what I would recommend is just really recognizing that there are multiple ways to treat and to be open to that. And Rebecca is going to jump in too.
Yeah, I just wanted to add, knowing that part of the screening is also kind of meeting women where they're at. And as long as we're not talking about a crisis situation, something you could consider doing is, offering them, I just leave you with these resources. You've got them if you need them. And that way, maybe you do a quick review. If you feel like you want to give someone a call, this is someone who I'd recommend, or here's a support group, or do you have any friends you could call? And if you're going to be following up with that mom, maybe at the next visit, maybe that's something that's high on your radar, that you follow up with the mom and kind of check in with her how she's doing. And maybe it doesn't even need to be in a formal screen, but just as a conversation too. But I think just even leaving her with some resources so she can call when she's ready is important.
Thank you, Rebecca.
Okay, are there any other questions on the line?
London, I guess one thing I'd like to emphasize that for those of you who have had training in motivational interviewing, I think this is a really good place where those motivational interviewing skills come into play. As Rebecca said, just meeting a person where they're at is so critical. And assuming it's not a crisis, you've got some time to think about, to stay with the mom and really think about what is going to be in her best interest. What is it that she'd really like to try? I think the point I'd like to emphasize is that there are a lot of different things to try, and to just helping the mom understand what's available. But but knowing that meeting her where she's at and recognizing that it's her choice to make, but while instilling hope at the same time.
Okay, any more questions? You can enter them in the chat, remember, or you can speak because the lines have been unmuted. All right, it doesn't look like anything else is coming in. But a reminder that if you have any questions that pop up after we are finished today, you can email them. Email address on the screen here, health.fhb@states.mn.us, and we will respond to you as soon as possible. Also remember that this is the second webinar in the three-part series. The third webinar will occur on March 16th at the same time from 11 to 12:30, and we'll focus on perinatal mood disorders and interventions for these. If you have not yet registered for that, there was a flyer that was included in yesterday's Tuesday topics that includes the link for the registration, and we can also send that out to everyone that participated today. So that's it. Remember, if you have any more questions, to please email us. Otherwise, have a great day, and thank you for joining us.